This is the story of how little warfarin can change the world. Story begins during the 1920s when many cows died with unreasonably internal bleeding. The livelihood of farmers in the Midwest of America was threatened seriously. Later, people found out the moldy sweet clover was the main cause, and called it sweet clover disease. This brought attention to Dr. Carl Paulinck in 1945. He synthesized from blood of a cowhead the disease, a compound called warfarin, as rat poisoning. The name warfarin is separated into two parts. WARF, W-A-R-F, is from the Wisconsin Alumni Research Foundation, which granted the research lab. And ARIN from coumarin, aromatic organic chemical part in the warfarin structure. However, 6 years later, a U.S. Army inductee attempted suicide with multiple doses of warfarin, but fortunately was recovered by vitamin K. After this incident, warfarin was successfully applied in clinical use in 1955, but it needed 23 years to discover its mechanism by John Sutter.
Since warfarin is an anticoagulant used to prevent harmful blood clots, it works to alter the conditions required for our body's coagulation factors to operate. The main coagulation factors in our bodies, such as prothrombin, have glutamate residues which are vitamin K dependent. These glutamate residues must be carboxylated to form gamma-carboxyglutamate residues in the liver in order for the clotting factors to function, because only the gamma-carboxyglutamate residues are able to bind with the phospholipid membrane surfaces of cells to activate clotting factors. Importantly, in addition to oxygen and carbon dioxide, vitamin K is essential for this process as well. This is the target of the warfarin mechanism of action. Warfarin acts as a vitamin K antagonist by disrupting the vitamin K cycle. In the vitamin K cycle, vitamin K is reduced by vitamin K reductase to vitamin KH2. Vitamin KH2 then catalyzes the carboxylation of glutamate residues to gamma-carboxyglutamate residues and is itself converted to vitamin KO. Vitamin KO reductase lastly converts vitamin KO back to vitamin K, thereby completing the cycle. Warfarin interferes directly with this last step. It interacts with vitamin KO reductase so that vitamin KO cannot be converted back to vitamin K. Thus, there's a depletion of vitamin KH2, and the glutamate residues cannot be carboxylated, and there's a limited supply of gamma-carboxyglutamate residues. As a result, the coagulation factors cannot bind to the membrane surfaces of the cells, and the coagulation process is hindered.
From a biochemistry perspective, this mechanism can seem quite complex, so let's look at it like a factory production line. As shown here, the vitamin K cycle, in blue, runs parallel to the production of the gamma-carboxyglutamate residues, in red. Vitamin K is shown in purple, vitamin KH2 in silver, vitamin KO in black, the glutamate residues in white, and the gamma-carboxyglutamate residues in green. Vitamin K is converted by the enzyme vitamin K reductase to vitamin KH2. This then reacts with the glutamate residues from the liver on the surface of the enzyme gamma-glutamyl carboxylate to give the gamma-carboxyglutamate residues. These are now active and ready to be converted to coagulation factors when the body needs them. At the same time, the vitamin KH2 is left as vitamin KO, which is finally converted back to vitamin K by vitamin KO reductase. However, when warfarin is added, it acts like a big red button shutting down the factory process starting at the vitamin KO reductase. This stops the vitamin K cycle and subsequently the carboxylation of the glutamate residues. Obviously, as with any analogy, there are drawbacks, such as the fact that the reactions aren't as simple as going into machines and coming out as the next part. Also, warfarin acts as a chemical blockage by binding to the active site of the enzyme rather than a physical one as shown, but to depict the complex nature of these cycles, this analogy is effective. Warfarin is the 41st most prescribed drug in the US, with over 19 million prescriptions. However, it is also third on the list of drugs associated with hospital admissions due to adverse side effects. These side effects include, but are not limited to, gastrointestinal bleeding and hemorrhaging. As well as this, warfarin patients are also dependent on the drug, as studies have shown that patients who come off warfarin suddenly experience more blood clots. There is currently no method for determining the correct dosage of warfarin to reach the desired anticoagulant concentration. As a result, patients who are prescribed it must undergo frequent monitoring at the hospital and potentially be prescribed vitamin K if the negative side effects are prevalent. This is costly and time-consuming for both patient and medical staff. The large variation in warfarin dosages is concerning, but this has led to research into more accurate methods to predict this. This, in turn, can be applied to other drugs, thus making the implications of this research more wide-reaching than just warfarin itself. Warfarin has been in use for over 60 years, and although other anticoagulants have been developed in that time, the same negative side effects still occur in all of them. However, warfarin is the cheapest of those currently available, hence its continued use till today. This brings up the question of whether the pharmaceutical industry is doing enough. With the drug being out for over 60 years, should there be a better alternative available that reduces the risks associated? Despite warfarin's benefits, with it being cheaper and proven to be effective, should there be more innovation? We are the champions, my friend.